We're here to talk about L5-S1 ALIF in the lateral position. So now, Dr. Varma.
So I want to thank the Society for letting me share my experience for the last couple of years. Just one thing I wanted to clarify. So I have no disclosures or financial conflicts. The discussion yesterday about the lateral versus the oblique, and that was a good discussion. At L5-S1, it's a different discussion because it's really the same procedure. There's not different retractors, but the exact same procedure conceptually. So it'd sort of be like having the total knee named something different depending on which company was your knee you were using. So I think it's really the same thing. For this, it happens to be OLIF, but it could be either. So in terms of incorporating this into my practice, why do we consider this? Is it better for the patient or the surgeon, or is it just new technology? And then also, some of the difficulties in something that's a leap like this at times is how do you do it? How do you safely incorporate it into your practice? And I'll kind of share some of my progression of cases and my experience and how I sort of approach that. So two kind of general reasons. One is it truly, in terms of why, it is a smaller footprint. I think as surgeons we're always looking for that opportunity to have a smaller surgical footprint and achieve what we want. You can see from what we've already seen in these last two talks and this image here, it is a smaller amount of dissection to get to an ALIF, to achieve an ALIF. And in fact, even the lateral positioning can help. It can also be problematic, but it can also help you achieve that. And then certainly what's been mentioned about saving time and saving a flip. So in terms of this image, it's actually a pretty cool image. It's a CT scan of someone supine, the same person lateral, and the image on the right really highlights how much of that retroperitoneal space opens up just by putting someone lateral and really almost facilitating some of your approach. I don't know how many of the younger surgeons actually do their own approaches for ALIFs. It's different, obviously, when you have to mobilize all the peritoneum. Here, you can actually fairly easily get down to the psoas and the disc space just with your finger because of what you see right there. One note is certainly that the iliac vein, also the left common iliac vein, also does fall more midline when you put a patient lateral, so it's something to consider. So it can help you, it can also cause problems. Interesting. This is just the same thing with the retractors in place, and also just kind of illustrates the same idea in terms of lateral versus supine, but achieving ALIF. So in terms of saving a flip and saving time, that's the other obvious benefit that we can harvest from doing things with this technique, whether it's single-level front-back surgery or multi-level surgery or deformity surgery. Certainly saving a flip and saving time matters. There were some problems with flipping, so it's not totally benign like was mentioned before. Anesthesia doesn't like it. You can certainly have issues where you lose a line, airway issues depending on the experience of the person or the vigilance of the anesthesia team. Foleys have come out, in certain cases. If you use monitoring also can have issues where all their wires are tangled, or especially if you flip a table or change tables. And contamination is a real phenomenon. I think we all know it. There's data to support it, but certainly there's a fair amount of OR traffic depending on how your OR runs. If you change tables, if you have floor machines coming in and out, if you have to bring in whole separate trays for the next stage of the procedure, and certainly personnel coming in and out of the room, during that flip, all this is a real phenomenon. Kicking up dust particles. If you have a back table that's trying to stay sterile between the flip, is it really sterile? Did someone brush up against it? Did particles fly all over it? These are all real things, redraping, and I think it's definitely not benign. Saving time, so again, are we doing this because it's convenient, or is it actually better? There's lots of literature across all aspects of surgery that supports that speed matters in terms of patient outcomes and quality measures. So I don't think that's anything that's not intuitive to all of us as surgeons, but there's data that supports that. So in terms of in terms of that, there's length of anesthesia that you expose your patients to, and certainly with older patients, that's more and more evidence is supporting how that does affect them. And as much as we maybe don't want to, admit it, or I think it's more that we don't want it to be the case. We want to train ourselves for it not to be the case, but that doesn't necessarily mesh with the data out there that surgeon fatigue matters and team turnover matters. There's a lot of literature actually about teamwork and having a consistent team and how that affects how well the operations go, complications, length of anesthesia. And certainly if you get into longer cases, all these things add up. The value, the same image that was shown before, but the value of single position surgery, you can achieve a front back one level, but certainly you can even achieve multi-level front back surgery in a single position. Navigation and robotics are increasingly being used to help facilitate that. And even if you are still flipping like in deformity, if you can't correct everything you need to, still kind of avoiding the 3-position deformity surgery is powerful. There's lots of posterior fixation options, as we all know that to be the case. But the one thing that's important to point out is that in terms of L5-S1 specifically, you don't necessarily even need to go to the backside for fixation. We've talked about that at L4-5 and 3-4 and so on, but that's more related to how those levels are accessed and then accordingly instrumented, whereas at L5-S1, because you're really just doing an ALIF, you can get a plate on if you feel so inclined and you avoid posterior fixation altogether. In terms of deformity, I think that's, or multi-level surgery, I think that's really, an important idea that you can access all these levels, starting from the base and sort of, like was mentioned before, sometimes you don't know what to do with L5-S1. In your gut, you really want to build from the bottom up, and this certainly allows you to do that as opposed to lateral or traditional lateral or ALIF approach where you kind of have it's hard to get above L3. In deformity surgery, this image right here kind of illustrates that. It brings 5-1 back into play. For the longest time, you really want to get a robust cage in there. You want to build lordosis. You want to augment fusion rates. If you get a plate on, you have more robust fixation. All the things that you really care about, and yet sometimes you shy it away from it because, a third position. So maybe you just try and sneak a TLIF cage and do some, facetectomies or something like that. But you really, would want an ALIF if you just could get it. And now, you can, without having to expose the patient and the team and the whole operation to a whole nother position. It's definitely worth mentioning the vascular anatomy, and I think that I want to highlight that for a few minutes here. As spine surgeons, we think about it. As anterior surgeons, we think about it, but you really have to think about it here in terms of all of the iliocaval anatomy, and there's a lot of variants that are known. There's other things that I hadn't really thought about before that I've become aware of in talking with different access surgeons and vascular surgeons, and you really are kind of near the great vessels. You really have to think about things like May-Thurner and proximal venous stenosis and just about how you mobilize these vessels. In talking to the vascular guys and the access guys, it's not just my feeling or their feeling, but I've seen it that they're definitely more comfortable mobilizing the vessels, and even if they get into them, repairing them and continuing with the procedure if someone is supine, and it's definitely challenging in the lateral position. So something definitely has to be thought about. It's an advanced procedure. It's advanced technique, and you really, I like to think about it, and would encourage people to think about it as something where you really actively collaborate with your access surgeon at L5-S1. Can you do it alone? Sure. I think it probably depends person to person. I would encourage people to think about it that way because there's certainly an opportunity to crash and burn. And so I think you have to sort of really look at all this stuff, because a lot of times we indicate these patients in our office before we even talk to an access guy. And I think if the more we sort of have our eye on the vasculature and sort of think about the things that are at play before we just sort of dump it on them, and sometimes people will just say, I'll meet you in the OR, and then you haven't even had a chance to look at it. So I think it's definitely worth taking a pause when you do this procedure. So just some of the slides I've borrowed here, this just highlights, the important relevant vascular anatomy at an axial 5-1 slice. But you really have to kind of figure out, so where is the location of the left common iliac vein, when you're thinking about your approach? What's the morphology of it? Is it elongated? Is it thin? Is there a fat stripe plane between that and the disc space? Like you see here, the shape of it. All these things there's not that any one of those things I said is an absolute contraindication, but you really have to start thinking about that, I think, before you can, move on to doing this, as shown in these slides here. There's a paper that shows, the ideal, the Netter's drawing shows the ideal anatomy, but there's papers that describe the variants, and there's certainly, those CT coronal images there, you can see the right internal iliac vein draining into the left common, the left internal draining into the right common. So all these things suddenly now, not suddenly I should say, but they all matter. They mattered even in a supine ALIF. I think, the access guys typically have an easier time handling things in an open supine case from their familiarity, and certainly their experience in a MIS lateral scenario is only going to be as big as yours is, because they wouldn't have otherwise had to be there. So they would say they're not that comfortable either in certain scenarios. May-Thurner syndrome, something I hadn't really thought that much since medical school. This idea that the right common iliac artery does drape over the left common vein and can compress it, and then you can see distal engorgement of the vein, as on that venogram there and on these cartoons, and that certainly affects things in terms of depending on how much you have to mobilize that vein. And sort of really some of the other clues that tell you there may be other things going on. On these images here, you can see a dilated iliolumbar vein. You can see a dilated ascending lumbar vein. And these things sort of key you in that this patient might even have proximal venous stenosis. And does that affect how you think about their vasculature when you're thinking about safe access? So I think, it's certainly an opportunity to collaborate with your access surgeon actively, where you kind of have your eye on these things. You can talk with them and have an intelligent back and forth, so you make a good plan and you don't crash and burn. And this image on the left is just an algorithm that one of the access surgeons I know has shared with me in terms of how he sort of thinks about how difficult or reasonable access will be. And one of the things is certainly that if you're doing an MIS lateral approach, it's an advanced technique, and that changes sort of just the risk profile, and you have to think about these things, and I think it's worth highlighting. So some of the general thoughts and kind of polling a bunch of different people I've visited and spoken with, in terms of the vascular considerations, the location of the left common iliac vein, whether they're thin veins. A lot of times people feel that in elderly patients, especially women, the veins are often quite thin. Whether there's a fat plane, whether there's engorgement. Certainly in terms of patients, if they're obese, it's not a contraindication, and it can actually help you, versus supine, but it also does make some of the same MIS stuff a little bit tricky, especially if you're not familiar. So it doesn't mean you can't do it. It's not a contraindication. It's just in terms of thinking at how to sort of incorporate this step by step, certainly if they've had prior surgery. And then certain orthopedic issues in terms of spondies and osteophytes and modic changes might affect how stuck things are up front, and how easy it's going to be to mobilize some of the vessels. So, you have the super users, and I think their experience is amazing. It's the things that people can do is fantastic. I always try to wonder, is that the same as what's generalizable to everybody, and how do I get from where I am to where they are, and without taking that leap of faith and which could be risky. So I think for me, in my practice, I just try to figure out, all right, what are the steps to get there from a safety standpoint. I think if you have a vascular issue, you don't want to then be calling for a vascular surgeon or calling for vascular equipment. I work with an access surgeon. If we have all their equipment in the room, it's not like we're calling it from another pod if we need it. The cell saver is available if we need it. And I think there's a real difference between doing this as an outpatient procedure in a true hospital versus doing it in a surgery center. If you God forbid, get into a venous issue, there are massive transfusion protocols in place at typical major medical centers that you just don't have access to, and it's not really the right setting to pack and jump in an ambulance and run. I think, I would encourage doing this at least in a hospital and seeing how your results are before even thinking about that. And then in terms of just the actual procedure itself, it's like anything else that's new and unfamiliar and uncomfortable. You have to figure out how to troubleshoot it and build your workflow. I use hip positioners because when you're malleting the implant in, it can move the patient, and sometimes tape isn't enough. We've messed around with the incision placement in various different ways to try and help facilitate getting a direct anterior access versus sort of an oblique access. The different tables matter in terms of when you're imaging, and what was said before about the retractor, and when you flip from an AP to a lateral, does it ding the retractor, and all of a sudden you have a huge problem. So all these things you have to get troubleshot, and then certainly when you're putting cages in, there's so many cage options and instrumentation options. And when you're working in a small space, you want to always just make sure you're feeling safe, that you can see everything you're doing. You're not putting sharp awls and things in under X-ray, but you can't see, and you don't know, well, I just malleted that cage in, and somewhere in that process, the vein popped out from under the retractor, and now I'm putting an awl in, and I can't see. So there's a lot of things you have to kind of troubleshoot stepwise. And then certainly your access surgeon, like I said, they haven't done this if you haven't done this. So they need to get more comfortable and proficient with kind of sweeping the adventition, moving the vein around in that position through a limited access approach. So I'll just go through a couple cases. This is sort of the idea of starting with a chip shot, and I think that the axial image shows the location of the left common iliac vein and how far off it is to the side, and this is sort of an open corridor. So I think in this situation, I think this is an ideal patient to start with in terms of trying to incorporate this into your practice. And then kind of building off of that, I then sort of took it to a 2 level. So this is someone that has the same favorable L5-S1 anatomy as seen on the bottom axial slide, and then they're also now favorable for a lateral approach or an oblique approach or whatever at L4-5. So I think these are all sort of stepwise ways that I think about it. And then you can, like I said, they're not necessarily absolute. There are some probably contraindications, and not that I would say these are absolute, but this is a little bit harder. This is someone that has chronic, discogenic back pain. But if you look at the position of that vein, you're definitely going to have to mobilize it laterally, and there's not an obvious fat stripe between that and the anterior annulus, and that's going to take a little bit of work. And both you and your access buddy are going to have to do some work to get this done safely. It's definitely different than the chip shot that I was showing you a second ago. So in this situation, I did the same thing. It's a very similar patient, very similar anatomy. Looks like it's doable. But as we get in there and you start to mobilize, sometimes you just can't enough to get in the instrumentation. So we could get a cage in, but I could not safely see a window where I could get a plate on. We just couldn't get enough exposure to safely do that. I think sometimes there's value in sort of just stopping and saying, wait, I can't do this. So I just need to flip it and put screws in the back and stop. It's not going to happen, rather than just trying to force it. So I think as you're building, you get the hang of it, your team gets the hang of it. There's a lot of people involved in terms of your retractors and imaging and so on and so forth. We've probably all been through that same with just lateral surgery over the years. But then you can sort of see the benefit of it. This is someone that's had a prior, multiple surgeries, prior 2-5 Lamy fusion. They've got breakdown above and a spondy below, and sort of how do you address that? Can you get it all from one position in terms of the anterior column before you go to the back? And I think this illustrates some of the power of this in terms of saving a flip, saving time, saving another exposure to the patient. And sort of just to kind of keep yourself humble. I mean, just when I thought we had it all figured out, and I think we've got it all sort of we're gaining steam, there's certainly a role for caution. And this is a similar situation, multiple prior surgeries, problems above, problems below. You kind of want to get all the anterior column access from one position And if you look at that axial slice, I think, based on the progression I showed, there's obviously a lot more cases between the first one and this one. This 5-1 seems doable. I look at where that vein is and whether there's a fat stripe, and it seems like it's doable. So there's a lot of images here. If you just follow from the left column to the middle to the third, I think the axials are really the most relevant in terms of really kind of scrutinizing the venous anatomy. So on that first image, we're seeing the beginning of the left common iliac vein. On the second image, we're seeing it underneath the right iliac artery. And then you see in that third image in the bottom on the left where it sort of really has an indentation in it before it sneaks out, crosses, and starts to drape down. And if you look at the subsequent slices, it looks fairly large. This is all nice in retrospect, and kind of helps me realize how much you really have to scrutinize this stuff, because when we got in there, we couldn't mobilize it, and it was engorged. It was much larger than we had thought it would be. And as the vascular surgeon was trying to move it and trying to mobilize this, there was a small laceration, and you basically had to pack it. And I think in that position, it's hard to sew the vein through a small retractor in the lateral position. You can get control, but for that moment when the wound gushes up, you have to think twice. Well, number one, you don't want to be in a surgery center, I don't think, when that happens. But number two, even after you get control, it's hard to then mobilize an injured vein. So we kind of had to abort. We didn't want to put the patient prone and have a negative pressure cavity that day, so we staged it and went back and did everything from behind. But this patient had May Thurners in retrospect, and I talked with the vascular guy, and he's like, yeah, we just, we still haven't really thought of, we're thinking of spine and we're thinking about vascular, and we really have to think about those things together and collaborate, and it just sort of helps us get smarter. So, yeah, so just so these are the last two cases. This is just again, we all know the power of minimally invasive anterior column surgery. If you can get it right, it's a powerful tool. This is a patient that went home post-op day 2. And you could get all the way down to 5-1 just as we wanted to. And this is just another case where, in theory, I would have loved to have done this all in two positions. This is a guy with a fracture, and he has a chronic spondy. You can see that here, progressively collapsing with retropulse fragments. On that axial slice, it looks like we should be able to safely do 5-1 from a lateral position. But sometimes you just feel like, am I going to be able to do this? And you just have to figure out, if you're ready yet. So I just decided to do it as an ALIF. I figured I would get faster access in a long case and a better anterior-posterior reduction. But it took more time. And in a perfect world, it would be two-position surgery. So it's definitely an evolving process. I just wanted to kind of highlight a couple thoughts. I think it's a useful technique. I think it's basically a minimally invasive ALIF. It allows single position surgery. It brings back 5-1 into deformity at times. I think safety is very important. I think you have to be an active collaborator. And I just think it's important to, something I learned from one of my mentors in terms of being responsible about adopting and incorporating new technology in a safe and logical way. Thanks.